the settings, but here, after you do like, do you have a Mac or a PC?
I have a Mac.
I turn things over to Michelle.
Thank you. And I'm just going to share my screen. Okay. So thanks so much for having me here today. I'm very happy to be here and talk briefly about an introduction to depression. I just wanted to say that we have 2 additional CAP ECHO webinars coming up, one about SSRIs and one about suicidality and safety. So I'm not going to focus on those aspects today in my brief 10-minute didactic. I'm going to talk a lot more about the following, which is how does depression present in children and teenagers? I'll talk about how to screen for depression and then how to do a depression assessment. And then I'll talk about determining the level of severity of depression and then sort of triaging into the appropriate type of treatment. And I have nothing to disclose. So first of all, how does depression present in children and adolescents? I like to think of the big 3, which is one is sadness or, tearfulness, dysphoria. Sometimes instead of sadness, in children and teenagers, you can actually see a type of irritability where they're very moody, very grouchy, very, they've got a short fuse with their parents. And then the other flip side of sadness and irritability, sometimes you'll see teens or kids who are depressed who really just manifest with anhedonia, and that's a lack of interest or deriving pleasure from activities that they previously enjoyed. Between children, school-age kids, and younger and adolescents, there can be some differences in presentation in terms of, how depression really manifests clinically. So for kids, often we will see them coming in with somatic complaints, headaches, stomach aches. Often those, once you dig a little deeper, that can actually, really reflect some underlying depression or anxiety or other behavioral health complaints. Often for kids, you might see irritability, as I mentioned before, as well as separation anxiety. That can really be a sign of something, going on that's more than just sort of, that reluctance to be apart from their parents. Often, kids who are sad can, act out, and they can have behavioral problems. They can complain of boredom, and they can also, in more rare cases, report hallucinations. For teenagers with depression, their depression can look a little different. Again, similar to younger kids, they can also have irritability, sort of beyond normal teenage moodiness, and sometimes that's difficult to tell. They can also have behavioral problems, acting out, rebellion, going out and doing dangerous things, or again, just being very oppositional. But unlike younger kids, teens are more likely to report sadness or dysphoria, changes in mood. And unlike younger kids, teens are more likely to tell you about feelings of hopelessness, nihilism, suicidal ideation, and actually do things that are dangerous to themselves, such as suicide attempts or self-injurious behaviors. For some teens, they can experience an atypical depression. And what I mean by that is typically in depression, we tend to think of kids as, having insomnia, having a lot of difficulty falling asleep, and then, with a loss of appetite. But in some children or teenagers, they can actually experience as more of like a hibernation type of picture where they have increased sleep and appetite. And that can also, reflect depression, even though it's a little bit unexpected. I also wanted to highlight that parents and children may report different symptoms to you. And so parents may tend to report, that irritability, the moodiness that they're observing in their child or teenager. They may be keeping track of appetite changes and sleep changes in a way that their child isn't, versus, in your conversation with a child, they may be complaining again more of, the physical discomforts, stomach aches, headaches, difficulty concentrating or being able to stay focused in class. And then for the older children and teenagers, a sense of hopelessness, nihilism, or actually thoughts about death. So the next part is how to screen for depression. And I know that most of your practices are already doing routine screening for depression for teenagers, but we have a variety of tools to screen for depression. thankfully. And the two that we like the most are the PHQ-9, which is validated for over ages 12 and over, and the SMFQ, which is validated for the slightly younger age group over 6. So for the PHQ-9, which probably is the one that you're most familiar with, it's great in that it can both tell us when you have a positive screen, which is a score over 11, as well as helping us to really kind of get a sense immediately just from the screening tool of how severe the depression is, and really, determining how much distress there is in a teen's life in terms of how frequently they're experiencing the depressive symptoms. Once you have a positive screen, you'll want to go ahead and have a conversation with the teen, the child, or the family to really flesh out the aspects of the depressive symptoms. So I will talk about the DSM-5 criteria for depression in the next slide, but I also wanted to highlight a few other key components in your assessment for depression. One that you're already doing routinely, which is the psychosocial assessment, the HEADS assessment, gives us a really good picture of just how the teen is functioning, in his or her environment, and all the other kind of social aspects of their life. One really important sort of keynote to remember is that, we don't diagnose depression unless there's an impairment in functioning. So really getting a sense of whether or not and how well the child is functioning in 3 domains is really important. And those 3 domains are at home, so with the family, at school, and how they're doing, kind of with their teachers, getting their schoolwork done, and interpersonally or with other peers. We think of the similar 3 domains for adults, but we replace school with work. So really school is a child's workplace. And then again, to just provide more context for understanding, why the depressive symptoms are occurring or what else may be happening in a child's life, you want to think about stressors, both the acute stressors that are happening, such as, the pandemic, shelter in place, having to stay home, versus the chronic stressors and chronic stress in a child's life, and any history of trauma. And I know a lot of you are already thinking about ACEs, and many are doing Pearl screening. So, that all fits together really well in terms of being able to understand the child, both in terms of his or her current symptoms and the broader picture of, what's going on for in their life and in their community and environment. And lastly, again, I won't talk too much about this, but you'll want to do an assessment for safety when there is concern for depression. And so asking about, whether or not the child has had thoughts of death, has had thoughts about wanting to end their life, and then determining whether that suicidal ideation is active or passive is really important. And we'll be talking about that more in a subsequent ECHO webinar. I wanted to share a few pearls that I always think of when assessing for depression. First, I think it's really important, if possible, to try to interview the patient and the parent separately, because a lot of time there may be some reluctance on the part of the child to really share some aspects of how they're doing with their parents. And so again, with teens, emphasizing confidentiality, I often tell teens, once we're kind of in a separate environment from their parents, that everything they tell me is confidential unless there's a concern about safety. And the only time that I would have to break confidentiality is if I was concerned about safety for them. So if they were, thinking about harming themselves or thinking about trying to end their life, then, we wouldn't break confidentiality, but all other things that they share are, sort of sacred under patient-doctor confidentiality. It's also really important to ask about symptoms, because a lot of teens are not going to spontaneously volunteer, different aspects of how they're doing or what's stressing them out. So really asking, and part of asking well, I think, is using normalizing statements and really validating. And so a normalizing statement is kind of something like, given all that's going on in the world and all the stress that teens are facing today, a lot of, teenagers are struggling with depression or sadness, and is something like that going on for you? How are you doing? And then lastly, if and when possible, it's also really helpful to get information additionally from parents, teachers, counselors, therapists, anybody else involved in the child's life, So, kind of putting together a broader picture from different dimensions is helpful. So the diagnostic criteria for depression is based on the DSM-5 criteria. And basically what you need to be diagnosed with depression is 5 of the following symptoms in a 2-week period. And one of these 5 symptoms must be either depressed mood or anhedonia. And you probably remember this from medical school, but we have that mnemonic SIGI CAPS. And so, the 5 symptoms come from a list including sleep changes, whether that's increased or decreased sleep, loss of interest in activities, feelings of guilt or worthlessness, lack of energy or fatigue, poor concentration, or sometimes that manifests as difficulty making decisions, appetite increase or decrease, psychomotor agitation or retardation. So that can be like a restlessness or increased motor activity versus kind of a lethargic, slowed movement. And of course, depressed mood, and then of course, suicidal ideation. We have the PHQ-9 to help us understand whether, the child is experiencing a mild, moderate, or severe depressive episode. But other things to think about in terms of the level of severity is the degree of distress that the child is in day to day from the symptoms that they're experiencing. And again, just to emphasize the level of functional impairment. So severe depression is high distress. They are impaired in, home or with their peers or at school, versus a more mild depression. Maybe they're experiencing a little bit of distress, but they're still going to school okay. They're maintaining their friendships. They're getting along with their parents. That's sort of what a more mild disorder would look like. I wanted to say a note about the differential diagnosis for depression and comorbidities. So I have here, this is a bit of an exaggeration, but think of it as comorbidities. Psychiatric comorbidities to depression are kind of the rule, they're not the exception. It is very, very common to have other mental health disorders that are comorbid to depression. The most common one is anxiety, but some of the other common ones include ADHD, oppositional defiant disorder or conduct disorder. For teens, often substance use and depression, anxiety, all kind of intermingle. And then more rare, but good to think about in terms of your differential, and always to keep in your mind, is bipolar disorder and psychosis. In terms of your differential, you also want to think about other stressors that are happening for the child. So instead of depression, is this bereavement? Is this a trauma response? As well as a variety of medical conditions or medications that can actually induce or resemble depression. So for example, hypothyroidism can look like depression. And we know that there are a number of medications out there, such as anti-epileptics, steroids, birth control pills, that can also cause changes in mood and cause teens to look depressed as well. So this sort of is a complicated chart, and I think you have this on your handout. But basically, I apologize for how small it is. I just wanted to highlight that, up here, these are the steps in which you're doing your screening, your safety check, your assessment. And then here you're deciding, is it a mild disorder, a moderate depression, or a severe depression? And I wanted to highlight that when it is the severe depression, that is, a really good time to think about referral to specialty mental health care, along with a variety of other reasons why you might want to refer to psychiatry, such as if there are safety concerns, a lot of comorbidities, if there's psychosis, if they have a lot of other medical illnesses where the depression is interfering with their treatment, or they're on 2 medications or have failed 2 medications. We think, a referral is appropriate. And I wanted to take a moment to talk about, how you can support a child and their family in monitoring and managing mild depression. So with psychoeducation, support, and ongoing check-ins. So a note about the psychoeducation support and monitoring piece. So psychoeducation is sort of a broad term and includes a lot of sort of that counseling and that talking that you're doing with the parent and child. And some of the techniques that you could offer are, making sure that they are getting good sleep, they're getting exercise, they're getting good nutrition, really sort of emphasizing self-care, doing things, activities that they enjoy and that bring, positive emotions, as well as potentially journaling positive events. You could also suggest or talk to them about relaxation strategies, or refer them to the CAP website, where there are a variety of resources on, the different relaxation strategies and information for family and teenagers. So some of those strategies involve kind of deep breathing, like from the belly, or imagery, like trying to imagine a really calm place, or repeating to themselves a mantra of like a really, kind of effective coping thought that they find to be soothing, or that they find to, help bring more positive emotions. Some of it, there are lots and lots of apps out there for a lot of different, anything you can really think of in terms of the mental health sphere. But I like to suggest in terms of kind of a coping tool, using either Headspace or Calm. Those are two great apps that really guide you through mindfulness activities and can help teens to, sort of de-escalate when things are getting more challenging, and to be able to manage their emotions and anxiety as well. Other than sort of the, kind of what they can do at home and a lot of these lifestyle changes, once we're moving to a more, mild, moderate, or more of a moderate or severe depression, you may think about a referral to psychotherapy. And there's two types of therapy that are therapies that are evidence-based. Cognitive behavioral therapy is the big one we think about. And IPT is also evidence-based, but I think just used less often here, and there's fewer therapists who do that. And I won't talk long about medications either, because that's coming up in another talk, but we have a number of medications that are FDA approved for children and adolescents and are very effective for treating depression. So, that's always an option as well, in conjunction with therapy. And then we have a number of, there's just lots of websites, lots of resources out there. Sort of these books are all on our CAP website, but there's resources for families, there's several books for teens and children about depression. So referring them, families and kids, to bibliotherapy can be helpful too. Okay, I'm going to pause my screen here.
Thank you so much, Michelle. We have like about 5 minutes, and so I want to open up for any questions about this particular lecture.
I have one. Sorry, I still can't get my camera to work. Do you ever find, so we do PHQ in our office, and I have some teenagers, especially if they're already plugged in with psychiatry,